So our next speaker will also be online. Our next speaker is Dr. Jean Panneton. Today, he's going to talk about the role of EndoAnchor in TEVAR. Dr. Jean Panneton is currently service in the Eastern Virginia Medical School, and he's also associate professor serving with Sentara Heart Hospital. So let's welcome Dr. John. So are you online, Dr. John?
Yes, I am.
Yeah, thank you. Yeah, sure. We can hear you clearly. So could you start your talk? Thank you.
Well, thank you. First, I would like to thank you for the opportunity to be there. Wish you a good morning. Here it's after 10 o'clock in the evening, so it's getting dark out there. And I'd like to thank also Medtronic for this opportunity to share a little bit of my experience with using EndoAnchors in TEVAR. These are my disclosures. So hostile neck anatomy is really commonly used to describe the infrarenal aorta, but what we do know is that the same hostile neck characteristics that we can see in the infrarenal aorta, we could actually also see in the thoracic aorta. And the same way that you can have this hostile neck anatomy, you can also have a thoracic aorta that is more prone to be unstable and will affect either early or late outcome in those patients. This is the HeliFix EndoAnchor implant system. It's a two-step process, and that's, I think, what makes it really intuitive at the same time as making it very safe, because the deployment is done in two steps. If the position or the location of the EndoAnchor is not optimal, you can always recapture that EndoAnchors and then reposition it in a better position, in a better place, and then finalize the EndoAnchor placement by releasing it completely as it penetrates the aortic wall. So the IFU, the indication for use for the EndoAnchors is really to try to provide additional fixation and sealing between an endovascular graft and the native aorta. And it's really better to use this really in patients that have either exhibited migration or an endoleak, or because of their hostile anatomy are more prone or more at risk of having such complication. It is really designed to augment radial fixation and sealing, and then maintain a proper aneurysm exclusion. And it can also be done at the index procedure, and it's definitely very useful as well in redo cases where the previous TEVAR has already failed. If you're familiar with the abdominal system, there's two abdominal systems, 22 and 28 millimeter, with a 16 French OD and about a 62 centimeter working length, and it's to be applied for aortic diameter between 18 to 32. Now, for the thoracic system, there are actually three guides from 22, 32, and 42, 18 French OD system, a longer working length, and it can treat aortic inner diameter all the way up to 42 millimeter. So when we considered using EndoAnchors, implants in TEVAR, it really has multiple applications, pretty much all aneurysm, all PAUs, as well as traumatic transection patients. We use those EndoAnchors in two modes, either prophylactically or therapeutically. And if you look at the reason we use it for prophylaxis, it would be patients with severe angulation, hostile necks, a difficult landing zone, or if there's a risk of having poor follow-up in certain patients. Trauma patients, for example, are known to have poor follow-up. We also use those EndoAnchors therapeutically to treat migration, to treat a type 1 endoleak, to treat bird beaking, as well as in redo cases. Words of cautions, however, to use EndoAnchors, not in aortic acute dissection or IMH, because we have a fragile aortic wall. Also in patients with connective tissue disorders, if the aorta has a thrombus lining the inside of the aorta, if there's circumferential calcification, and definitely if there's a porcelain aorta, and if the aorta is really dilated beyond the endograft and the EndoAnchors cannot reach the aortic wall. So here's a case I believe that will really exemplify the benefit of using EndoAnchors in these patients. This is a female patient, her late 70s, presented with severe upper back pain. She had had a previous triple E repair with an aortobiliac grafting, and she has a symptomatic, very large descending thoracic aortic aneurysm. I think the video here really exemplify how challenging treating this patient is, and the 3D reconstruction really shows this. So obviously this patient, I think ideally would be probably best treated by a zone 0 TEVAR, but obviously in an emergent setup like that, we try to see if we could actually do a zone 1 TEVAR by doing a hemiarch debranching. So we basically plan to debranch the left carotid and the left subclavian artery surgically, and this was then followed by a zone 1 TEVAR. The zone 1 TEVAR was done. Usually we do that with pacing wire. You can see we're really down into the really complex zone 1 TEVAR where we are, because it's a type 3 arch, deploying some EndoAnchors really at the proximal edge of the endograft. The patients that will have this sort of anatomy, we will do this prophylactically, not even waiting to see if by angiogram we see a type 1 endo leak. We will just do it prophylactically. This is the completion arch study showing actually a very good delivery, very precise, very accurate delivery, no endo leak, and you can see the debranching of the hemiarch there with 6 proximal EndoAnchors placed at that level. We also use those EndoAnchors prophylactically at the distal end of the endograft to prevent a cephalad migration. And this patient had the same thing, had the EndoAnchors placed distally as well. The distal end of the graft was placed all the way to cover the celiac artery in that patient. And here's a CTA with showing no endo leak at 23 months of follow-up. You can actually identify it on the 3D reconstruction some of those EndoAnchors as in the proximal arch, as well as in the descending thoracic aorta right above the superior mesenteric artery. At 3-year follow-up, the patient maintains no migration and no endo leak. So in my mind, it's very clear that this kind of very challenging anatomy, the only way to really make this durable, prevent migration and prevent a loss of seal is by adding those EndoAnchors, because they add active fixation to an endograft that's usually provides the seal only purely by a radial force. Now, is upward migration at the distal end of a TEVAR graft a real issue? We believe it is, and I think the VALOR 2 trial really showed that nicely. When you look at the secondary aortic-related reintervention rate, was approximately 5% at 3 years, but nearly 40% of those reintervention were for type 1B endo leak. And this is really exemplified here, that a CT scan showing this type 1B endo leak when the graft really pulls in a cephalad fashion. Here's an example of that. This is an 80-year-old male patient presenting with a 6.3 cm descending thoracic aortic aneurysm. And I'm sure you've all seen this, this kind of natural tapering down of the thoracic aorta as it tapers toward either the celiac or the superior mesenteric artery. And the tapering here is quite significant. It goes from 33 down to 25 millimeter. So when there's that much tapering, really you have a chance that the graft will basically pull up if you don't provide active fixation. We did a celiac catheterization here to have a good marker to deploy the TEVAR graft. I think the image here really shows how the TEVAR graft has tapered down. And if you just leave it at that, there's a fairly good chance that it will pull up over the following years. That's why we do provide active fixation at that level. And here's another example, another video that shows how the EndoAnchors or position circumferentially around the entire distal end of the thoracic aorta. And here's the completion angiogram of that patient with a graft that is very well positioned right at the takeoff of the celiac artery. That patient was nowhere intact, stable renal function. Obviously, we did have a CSF drain in this patient, which usually are removed at 48 hours. At 2-year follow-up, we have no migration, no endo leak in this patient. We did publish our experience with using EndoAnchors in TEVAR. Excuse me. And this was on 54 patients. 40 of those patients had thoracic aneurysm, 14 had thoracoabdominal aneurysm. So they did have to have fenestration into their visceral branches. Of those 54 patients, 50% EndoAnchors were placed at the index procedure, and yet 50% were redo procedures. So very complex patients that have already exhibited either endoleaks, graft migration, or aneurysm expansion requiring an extension graft. 5 of those patients presented with frank aneurysm rupture. We had a third of those patients were female patients. The mean age was close to 70 years of age. And you can see here, this is a distribution of EndoAnchors. It's about 900 EndoAnchors that were placed in those patients for a mean of about 9.4 EndoAnchors in these patients. You can also appreciate that zone 5 was the most frequent area where we placed EndoAnchors in these patients. This is basically the distal thoracic aorta right above the celiac artery. But specifically looking at the arch for zone 0, 1, 2, and 3, there's a fair number of patients. It's actually also a very common place for us to place EndoAnchors because we believe the aortic arch is such a hostile environment to have an endograft that will stay in there and position for a long period of time. The outcomes of those patients, we had a 99.8% technical success of EndoAnchors implant deployment. At the intended deployment, we had no instances of graft migration and very challenging anatomy. We had only 1 patient that developed both a type 1A and a type 1B endoleak. We had 3 patients with fenestration related to type 3 endoleak, nothing related to the EndoAnchors, basically. Looking at the freedom from post-op endoleak was 92%. 81% freedom from aortic-related reintervention, 90% freedom from aortic-related death, again, in a very complex patient population. But if you look at the overall reintervention rate for EndoAnchor implant failure, it was only 1.9%. Again, the majority of endoleak reintervention, the majority of aortic reintervention were not related to a loss of seal because of EndoAnchor failure. They were really related more to the fenestration issues that you see in thoracoabdominal aneurysm. So the summary of this experience was that I think it really demonstrated the potential to enhance thoracic endograft efficacy and durability with the use of either therapeutic or prophylactic EndoAnchor implants. They can really be used safely in endovascular repair of thoracic and thoracoabdominal aneurysm with very high rates of technical success and a decreased rates of endoleak formation. Obviously, we need longer-term data to really better define the use of this technology in the thoracic aorta. When we do plan the positioning and the placement of HeliFix EndoAnchors in the arch, I think it is very important to remember that the only way to climb up on the anterior or posterior aspect of the arch is really by deploying those EndoAnchors, by not changing necessarily the deployment view of LAO, but by really going into more cephalad and caudad orientation of the gantry to be allowed to place those EndoAnchors. Here's a few slides that really exemplified where we can really deploy those EndoAnchors. This is on the outer curve versus on the inner curve. Obviously, the inner curve deployment tends to be slightly easier than the outer curve. Here's a video that really shows a relatively easy arch because it's a flat arch. And it's relatively close to the aortic isthmus. So placing EndoAnchors on the outer curve is relatively easy, as opposed to an arch that's a lot harder to deploy EndoAnchors because we have to reach a lot longer into the arch. So it's a lot harder to actually make that turn up into the outer curve. But I guess with practice, it is definitely possible. This is an example of a patient that underwent a redo zone 1 TEVAR, and despite the redo zone 1 TEVAR had persistent type 1 endoleak, And all we had to do is place those EndoAnchors right here on the inner curve, and it actually completely eliminated that type 1A endo leak after that placement of EndoAnchors. Finally, I think one of the important technical aspect of implanting EndoAnchors is really what I call the angle of attack. You do have to be very perpendicular to the graft, and if the guide is undersized, you can see that you will not be able to implant the EndoAnchors, as opposed to here where you have a more 90-degree angle, and the EndoAnchors will implant very nicely. So these are my top 10 considerations for EndoAnchor implant usage in EVAR and TEVAR. The first one would be to take the time for preoperative planning. Wishful thinking does not create a landing zone. You have to learn to deliver the endograft accurately, first of all. We do the aortic balloon molding before we do the EndoAnchor implant. You need to size the helifix guide according to the aortic diameter, but you do need to undersize the helifix guide if you want to put EndoAnchors on the outer curve of the arch. I tend to deploy at least 2 rows of EndoAnchor implants in all EVARs and TEVAR, but when I'm in the arch, because the DPDT, the impulse in the arch is so much stronger, I deploy at least 3 rows of EndoAnchor in the arch. And I think learning to deploy EndoAnchors in distal TEVAR where tapers to the celiac is probably the best place to learn. And I would never start a challenging EVAR or TEVAR cases without EndoAnchor implants. I'm going to stop here, and I thank you again for this opportunity.
Thank you, Dr. Panneton, for your interesting talk, how to push the limit using this EndoAnchor to the arch and also the descending aorta. So now we are going for our group discussion. May I invite Dr. Ismazizi to come on the stage to discuss? Okay, I'll say, so I would like to ask my first question to Dr. Panneton. So about cases that may have a chimney stand on the arch, do you recommend we do the TESAR as well, and any challenges to do that?
Yeah, that's a great question with chimney. In fact, chimneys, if there is a great indication to place EndoAnchors, it's also because of chimneys. Because when you have chimneys, it does pushes the endograft away from the aortic wall. So you can actually target the chimney, the channel of the chimney, and basically place EndoAnchors on each side of the chimney. I tend to not use a lot of chimneys in the arch. I'd rather use in situ laser fenestration. I think it's probably a little bit more elegant, and the chimneys in the arch tend to have more type 1A endo leak because there's such a higher impulse. But when I do use visceral chimneys, clearly this is a great place to use EndoAnchor and eliminate the risk of gutter leaks.
Any question from the panel?
May I have one question for the EndoAnchor, sir? So, what is your decision about the for the 1A therapeutic 1A endo leak? What is your decision to choose the TESAR or the proximal extension? What is your preference or decision making?
I will say it's definitely individualized to the patient. If a patient, and also to the type of type 1A endo leak. There's type 1A endo leaks that are fairly small. The endograft and the aortic wall only have a very small amount of malapposition. And if you can actually target it with an EndoAnchor, I think it's a very elegant way to take care of it. Obviously, if the endograft is floating within an aortic lumen that has dilated too much, the EndoAnchors will not work. They will not, even if they can work to reach one side of the wall, they won't be able to reach all the other side of the wall if the aortic wall is too far away. Obviously, in good risk patient, in patient with longer life expectancy, I definitely tend to favor more a proximal extension if I have a type 1A endo leak, as opposed to simply use EndoAnchors. But when I will do the proximal extension, I will add EndoAnchors to it to just make sure that it doesn't happen again, losing a seal.
Yeah, please.
And Dr. Sean, may I ask some question? Do you have like a limitation of the stent graft size to use the TESAR technique? Because if there is a risk of the dissection for use of the EndoAnchors in the zone 1 or zone 0, so do you have the like a maximal size of the aortic aorta or the stent graft that you will use this technique or not?
Yeah, the largest Aptus guide has a radius of 42 millimeters. So it would be basically if you have an aortic diameter in the range of 4850, you would not be able to do a TEVAR either, and you would not be able to use EndoAnchors. So I would say about 42 to 44 of aortic diameter is about the maximum aortic diameter that you can use EndoAnchors with.
Thank you.
I have two questions. One question to Dr. Panneton. So do you think that the TESAR can prevent sign? Because in some cases we have a sign after we implant the TEVAR. So do you think that distal nailing of the wall can prevent sign? This is the first question. And the second question I would like to ask Dr. TT and Dr. Ismazizi. So what are your indication and timing to treat the non-A and non-B dissections? So maybe we start with Dr. Panneton.
So if you're referring to a D-sign, a distal stent-induced new entry, in dissection, if it's in an acute dissection patient, first I would not use EndoAnchors. I think that the risk of causing a D-sign by the EndoAnchors is probably greater than the risk of preventing it. So I think acute dissection or acute IMH, we do not use EndoAnchors in these patients. Now for chronic dissection, and I really believe that D-sign is really related to a TEVAR graft that's too short, that lands into the curve of the thoracic aorta, into landing past that curve. But I don't believe that EndoAnchor placement would help prevent a D-sign. That really is, I think, a chronic problem of having the endograft beating against the septum if the endograft is too short. Or too oversized as well compared to the distal end.
Okay, thank you. So my second question goes to Dr. Ismazizi and TT.
Okay, I think Okay, thanks. I think for me personally, I think in my center, I think I can say about 20 to 30% of patients who are coming is non-A and non-B. I think looking into the retrospective review, I think treating non-A, non-B in later stage give more problematics in terms of getting good remodeling in future. So for me personally, once I dealing with this non-A, non-B, I will treat early in the subacute phase, and I will do very aggressive. Try to get good sealing zone so that we will get a good remodeling of the aorta rather than dealing with the more complex in the futures. So that's my personal practice. Maybe Dr. TT have a different approach of it.
For my opinion, for the non-A, non-B dissection, I will divide patient into group that patient with the malperfusion or the complicated. In this group, I think we consider to perform in the urgency to emergency surgery. If the non-A, non-B with the non-complicated or maybe no malperfusion syndrome, we also wait for the subacute phase to perform the surgery.
Any consideration about the size of the aneurysm or the size of the arch when you come for the timing for the management?
I think so, have been outlined by Dr. Titi. I think if you divide into the indications, I think if malperfusions, I think that definitely we need to treat very early. That's the size not really the matter that much. If we're talking about the non-complicated, obviously we put it into the high risk groups. And then once you fulfill the criteria, definitely I will do early. And then, but if looking into the size, if the aneurysmal size, I think as long as it's not complicated and fulfill all the criteria, I think I will treat not according to the size, but following into the suggestions of the consensus. I have a question to Dr. Titi and maybe Dr. Angshu. I see a lot of the, I think we will see, I think maybe both of you been seeing all the patients who have been treated with the classical elephant trunk, they will come in the future with a huge aneurysm at the descending component if they don't get remodeling. And then for me personally, treating this condition are big headaches, especially to get a good sealing zone, and sometimes the classical trunk will be floating everywhere. So I think how you've been dealing with this kind of issue in your center, especially if you come across in treating in the acute period, you tackle it in the later stage, or you will just try to achieve remodeling for Dr. Titi or Dr. Anshu? Maybe just need to input from both of you.
In my point of view, so normally in non-A, non-B dissection, we will approach from the two things. First of all, is in complicated or non-complicated. So if there is a complicated dissection, you have to do it urgent or emergency into the condition of the patient. And also you have to look at the entry tear. The entry tear, if the entry tear is at the descending aorta, so maybe you can use some hybrid or the total fluorescent elephant trunk technique, depending on the proximal landing zone is good enough or not. If the proximal landing zone, the arch is quite large, or there are some hematomas extending to the arch. So if you think it's not safe, maybe you can select it to do the total fluorescent elephant trunk. But if you have the entry tear at the arch, so in this case, you cannot select the maybe rarely use of the hybrid approach. So mainly if the entry tear is at the aortic arch, majority of the case I use the total fluorescent elephant trunk technique. Maybe Dr. Titi have another approach.
I do as Dr. Ansu mentioned. I think so, but for the limasis at the descending aorta, we have to have the surveillance, close surveillance, and we also provide more stent down there, or maybe the consider to perform the open surgical repair for the remaining disease down to the descending aorta.
I just would want to mention here, Dr. Jamie was asking what are the criteria which you use, probably the sizing criteria which you use to treat these non-A, non-B dissections. I think the dilemmas are being put to rest in the recent past. These are earlier, traditionally we used to consider type A dissection, predominantly it's a surgical approach, type B dissections, predominantly an endovascular approach first. But here are some dissections which we think is type non-A, non-B. Now these are presently classified as type B dissections. The zone has been extended until zone 1. So the recent classification system puts the importance to entry tear with a mention about the proximal extent and distal extent. So if the proximal extent is until the zone 1, it is still a type B aortic dissection. It is no more a non-A, non-B dissection. So there are clearly indications which have been mentioned. There are some high-risk features of these aneurysms where if you have a false lumen diameter more than 22 millimeters, it is an indication for early intervention. We do not wait anymore for the total diameter to increase more than 50 mm or 55 mm. It is the false lumen diameter which is important. Malperfusions, yes, and apart from that, any entry tear in the lesser curvature is again an indication for early intervention. So there are some of these indications which have been brought about in the recent past which clearly define when to intervene in such patients.
Okay, I think it's times a very good discussion and interesting topic.